Morning, everybody. I would like to thank Dr. Muralidhar for this opportunity. I'll be talking on transesophageal echo assessment of aortic regurgitation. I think the views and everything has already been covered by Dr. Raj there, so I'll be repeating a few of the same slides. Actually, to understand the aortic regurgitation process much better, I have interposed certain surgical views as well as the case scenarios for us to understand how the valve looks during regurgitation, what are the case scenarios we are going to have on the aortic regurgitation. Yeah, if you can see the first this is actually a post coronary revascularization patient who has come back after 5 years with a severe aortic stenosis. If you can see, my cursor is pointing towards a calcific aortic valve, which you can appreciate it very easily there, and see the dye coming back into the LV. There is a severe aortic regurgitation. It is a combination of both AS as well as AR. Yeah. Yeah, actually compared to transthoracic echo, wherein the ultrasound beam has actually to traverse quite a large distance from the near field to the far field, that is, it is to go towards the skin, subcutaneous tissue, the muscular layer, the bones, and then reach the heart. Basically, in transesophageal echo, what happens is the probe is just below the heart, immediately below the heart, and the aortic valve is in close proximity to the probe. Hence, the tendency to get high resolution images is very high, and probably we are able to assess the aortic valve much better than transthoracic echo, and come to a conclusion whether this valve requires, whether it's feasible for repair or a replacement. So the transesophageal echo is much better comparatively. Now coming to the views, already Raj has already shown the views, the deep transgastric view, which you can see it now. This is deep transgastric view. So one of the important views, especially to assess whether it's stenotic lesion or regurgitation lesion, because it is definitely the ultrasound beam is much parallel to the blood flow. So this is one of the good views. Now suppose we are unable to get a view, not that in every patient you are able to get a deep transgastric view. You have an alternative view, that's the transgastric long axis view, wherein the beam alignment can be nearly as good as the deep transgastric view. This is another important view where if you are unable to get it there. And then we have the aortic valve short axis and the long axis. On the right side we have the long axis view, wherein you can assess the opening of the valve actually in the long axis, or quantify the aortic regurgitation in the long axis, or in fact in the short axis also you can quantify the regurgitation gradient in this short axis view, mid-esophageal short axis view. Now these are some of the important views to assess the aortic valve. Suppose we are unable to introduce a probe into the aortic valve, and we are landed up in a situation the surgeon wants us to quantify the aortic valve, what is the gradient or what is the degree of AR. We definitely have a alternative view of the epicardial imaging. We have it. So you can have the surgeon or one of us can scrub in and place the probe directly on the heart. You can have both the long axis and the short axis view, wherein you can make out here, if you see, this is the right coronary cusp, left coronary cusp, and the non-coronary cusp can be made out very easily. And this is the long axis view, wherein you can make out the aortic valve opening and closing. In fact, the LVOT also can be done here. Of course, it's difficult to get the gradient in this view. We have a epicardial long axis view, wherein we can assess the gradient across the aortic valve also. The most important thing for us is to assess the annulus size. The surgeon wants what is the size of the valve, how big is the annulus, he wants to know. So these are some of the important measurements to take across the aortic annulus, aortic sinus, sinotubular junction, and the ascending aorta, and inform the surgeon about the aortic annulus, and then he chooses the valve of his choice to replace it, or he wants to repair it, he can go ahead and repair it. Now coming to the basic causes of aortic regurgitation. So most of them are caused by either some intrinsic factors of the aortic cusp, or secondary for diseases affecting the ascending aorta. Those are the commonest lesions wherein it cause an AR, or because of some intrinsic problems like rheumatic heart disease, or calcific aortic stenosis, myxomatous disease, or endocarditis. And of late we have been seeing a lot of traumatic injuries, especially the history of falls. We can get a aortic regurgitation because of a torn cusp or something like that. In fact, I have one of the case reports here showing an aortic regurgitation occurring post fall. or it can be because of conditions affecting the ascending aorta like annular dilatation or dissections or Marfan syndrome. And chronic hypertension of course can lead to an AR because of annular dilatation. Now, just like how we have the Carpenter's classification for the mitral valve, L. Cowrie has designed a classification to assess the aortic regurgitation. That is type 1, there is a normal leaflet motion we have. Type 2 is the excessive leaflet motion, and type 3 is the restricted leaflet motion we can have. Now, further it has been divided, that is the type 1 is divided into 4 stages, that is with the normal leaflet motion. You have either the dilatation of the type 1A, that is dilatation of the ascending aorta and the STJ. So this will be the ascending aorta and that will be the sinotubular junction, or you have the type 2A, 2B, 1B will be the dilatation of the STJ as well as sinuses, and 1C will be the dilated aortic annulus, and 1D will be the leaflet perforation. This is further subdivided into these things. So it makes it easy to classify, and depending on what classification we have given him, the surgeon makes his choice of attempting the surgery, what kind of repair or replacement has to be done. Now, this slide shows the entire ascending aorta has been dilated. This is type 1. It comprises all these things, type 1A, 1B and 1C. Wherein if you see, there is complete effacement of the sinotubular junction. There is no this thing at all. You can't differentiate the sinuses, neither can you differentiate this sinotubular junction with annular dilatation, leading to a severe AR in this. Now I have a 48-year-old gentleman presented with a new onset of heart failure and diastolic murmurs 6 months back, who had suffered inferior wall MI, and he had undergone a PTCA to the right coronary artery, okay, with the EF of 35%, and he came back with a mild MR and a severe AR, and he was scheduled for aortic surgery. Now, if you look at this angio, if you can appreciate this in the two-dimensional echo in this long axis view, can you see a filling defect in the right coronary cusp in the region of the interventricular septum? There's the right coronary cusp, and you have seen the AR is occurring across the right coronary cusp. If you can see in the 2D, you can make out a filling defect. That is probably the right coronary cusp has been perforated. Okay. Now, you can see in the short axis view also, the jet is in the region of the right coronary cusp, not in the left or the non-coronary cusp. That means there is something wrong in the right coronary cusp. Now, coming to the surgical exploration, when we see here, you can make out the surgeon is operating in the vicinity wherein there is a tear in the right coronary cusp, and he is suturing that. This was the reason. Probably while he underwent an angio for during his inferior wall MI, probably the catheter perforated the right coronary cusp. That's why it led to an AR. Okay. Now the post-op images, when you see it, that is, there's a very mild AR in the region of the right coronary cusp. You can see it is quite good. Now you can see the jet, very small jet in the region of the right coronary cusp. It means the repair has been done, a patch closure has been done in the region of the right coronary cusp. And in fact, traumatic injuries of the aortic valve, okay, from coronary intervention is very rare. Okay, probably the jet tolerated the AR. The patient tolerated the AR for several months, which he had before presenting with a congestive cardiac failure. So it was consistent with the chronic volume overload of the left ventricle. Now we have another case here. If you can see here, it is in the region, you can get the AR in the region of the left of the non-coronary cusp. I am unable to make out, but there is severe AR in the region of the left of the non-coronary cusp. Okay, we'll have to assess on which side it is. Now here, if you see, the jet is located in this area. That is the non-coronary cusp. You can make out the non-coronary cusp completely. You can see in the short axis view. Okay, here also you can make out the same thing. And here, if you see, actually the non-coronary cusp was fenestrated basically. If you can see, the surgeon is handling this is the right coronary cusp, and here, when you see the left coronary cusp is pushing the probe into the, it is going into the fenestration in the non-coronary cusp, you can make out. And also, in fact, one of the small fragments of the cusp has been torn. You can see the oscillating fragment there in the region of the left coronary cusp. That was the reason for the AR, you can make out. And this is another case wherein we saw the patient underwent a diagnostic cath for suspected coronary artery disease. The cath was negative, but shortly after, the patient developed a shortness of breath. If you can see, in the region of the left coronary cusp, some fragment has been torn in the left coronary cusp. That was the reason for this AR. So even coronary cath interventions can sometimes lead to abnormal aortic valve problems, and traumatic injuries are being more common. Not very common, but still you should suspect after a cath when they come with some symptomatic signs. Now coming to the grade 2 AR, if you have there's prolapse of the right coronary cusp in the long axis, you can make out. Hence, the jet is directed more posteriorly. It is opposite to the direction of the prolapse of the segment. The severe AR is occurring, and the jet is directed towards the anterior mitral leaflet. Okay, or it can be due to. You can see here. This is one of the cases of a dissection. You can see the intimal flap prolapsing into the LVOT area, and this is causing a severe AR in this. This is dissection, of course, type A dissection is very common to land up with a severe AR. Or sometimes you can have AR. If you can see, this is the long axis view, where the membranous part of the interventricular septum is aneurysmal and is oscillating and is causing an AR there. So this is one of the this is the long axis view, and this is a transgastric long axis view, wherein we are seeing the aneurysm of the membranous part of the interventricular septum causing a severe AR. Or in fact, you can have endocarditis of the aortic valve leading to prolapsing of the cusp and causing a severe AR. You can see the thickened vegetations there and both the leaflets have been prolapsing. The right coronary cusp as well as the left and the non-coronary cusp prolapsing into the LVOT and causing a AR. And this is one of the images wherein you can see surgically, you can see all the valve vegetation, the thickened, more calcific, and this is how a typically endocarditis valve looks basically. He's unable to cut across. Actually, he's using a heavy scissors to cut open the valve basically. Okay. And this is another case of a 73-year-old man with a history of fall brought to the ER with loss of consciousness. He is intubated. A transthoracic echo was unsuccessful, and we did a TE. In fact, you can see there is a region of the AR there, and you can see also there is a pericardial effusion which is causing collapse of the right atrium. There is a systolic collapse of the right atrium, indicating a tamponade features have been there. And when this patient was taken up for surgery, post this thing, you can see the whole of the non-coronary cusp is torn. You can see this is the region of the valve which was torn there. You can make out very clearly because of the fall he had, and the whole of the cusp were torn basically. There is a torn valve, what you can make out. You can see the further there. You can see it better now. You can see the whole of the right coronary cusp as well as the non-coronary cusp being torn, and you are having a region. You can see the frailty here. That was the reason for the AR. Or it can be type 3. What I am trying to next is because of rheumatic. You can have a combined lesion of aortic stenosis as well as aortic regurgitation. You can have that can lead to AR. Now, how do we grade this aortic regurgitation? That's more important. Actually, there are many ways to. Normally, either we grade it in the long axis view. You measure the jet width by LVOT width. You can measure it. If it's more than 65%, they quantify it as severe. Or if you have a vena contracta more than 7 millimeters, it is set as severe. Or the regurgitation volume, regurgitation fractions, or the EROA, regurgitation orifice area also can be calculated. But normally, most of us try to eyeball it and measure the vena contracta and come to a conclusion whether it is mild, moderate, or severe. Or in fact, I use the jet width and LVOT width in the long axis view to quantify the severity of aortic regurgitation. That is much more easy. Or even the pressure half time. When you put your continuous wave Doppler in the deep transgastric view or the transgastric long axis view, you can quantify by pressure half time method. And this is the pressure half time method. What I'm saying, pressure half time method, pressure half time is actually the time taken for the LV to fill by half. So if the jet, the regurgitation takes a shorter time to fill the LV, that means the lesser the time, the more severe the AR jet is. So if it's less than 200 milliseconds, then it is severe. If it's more than 500 milliseconds, if it's taking a long time, then definitely it is milder. That's how you quantify this. And this is the way in the long axis view you measure the vena contracta or the jet width by LVOT. You put an M mode across the LVOT and measure the jet width and the LVOT width. You measure the percentage of this thing dimension, and this is about 65%. So definitely this is severe AR. You can quantify that. Now we have another situation here. Actually, if you have a patient with severe aortic regurgitation, this is the transgastric long axis view. You can see the jet is eccentric. It is hitting the base of the anterior mitral leaflet. See, this is one of the important signs which if we fail to understand. Okay, Suppose in the four chamber view you tries to analyze the mitral valve also. Now jet here is going from the right coronary cusp towards the anteromitral leaflet. This is an eccentric jet directed posteriorly, and this jet is hitting the base of the anteromitral leaflet and preventing the anteromitral leaflet from opening. That means if we understand, the AR also occurs in diastole and the mitral leaflets also open in diastole, but this jet is preventing the anteromitral leaflet from opening. That means it is causing a pseudo-mitral stenosis. Probably we might get a false reading of the mitral valve velocities or the gradients across the mitral valve. So we have to understand that eccentric jets, posterior direct jets can cause a pseudo-mitral stenosis. So we have to remember this. Or in fact, if you go to the basal view of the mitral valve, transgastric basal view, and you put an M mode across it, this is the posterior mitral leaflet, this is the anteromitral leaflet. Okay, and you put an M mode, you can see here the anteromitral leaflet is fluttering. Basically, fluttering of the anteromitral leaflet is a sure shot sign of severe aortic regurgitation. So please understand that it is very important even to assess the mitral valve when we assess the aortic valve. So fluttering of the AML is a sign of severe aortic regurgitation. And of course, calculating the regurgitation volume by this stroke volume across LVOT minus stroke volume of the mitral valve will give you the regurgitation volume, which is more than 60 ml. Can give you you can quantify it as a severe AR. Okay. Another thing, important sign would be for echo finding would be that is in the mid-esophageal descending aortic long axis view. This is the proximal end of the aorta and this is the distal end. You put in pulse wave Doppler across that. If you can see, this is your normal flow. And if you have a reversal of flow in the opposite direction, there is a holodiastolic flow reversal. This you can assess it in the ascending aorta, descending aorta as well as abdominal aorta. If there is a reversal flow in the descending aorta from the abdominal aorta, then it is termed as a severe aortic regurgitation. That's very, very important. We have to understand there is a holodiastolic flow reversal. That means in diastole the flow is coming back from the abdominal aorta into the LV. So that's very easy to quantify that. In fact, they have suggested that if you measure the VTI, velocity time integral, across the diastolic flow pattern, if it is more than 19 centimeters per second, it is quantified as a severe AR. Okay. Now here I have an interesting Doppler across the left subclavian artery. Normally the cursor is pointing towards is the left subclavian artery. It is a triphasic flow pattern, which actually in diastole there is no flow. In the next image I have on the right side, there is a flow reversal there which is occurring there. So this is a case of a severe AR. Next, post aortic valve replacement, absolutely in diastole there is no flow at all. That means the valve correction has been excellent. So this is how you quantify the presence or absence of AR. Okay, this I have done it on the left subclavian artery. This also you can assess it by that. This is what I was telling you about. You measure the VTI across the regurgitation flow, you can quantify it as mild, moderate, or severe. If it is more than 19 centimeters per second, it is quantified as severe. This is one image wherein you show the bileaflet mechanical valve has been placed in the aortic position, and you can see there is a paravalvular leak occurring across that. It is definitely a severe AR there post replacement. Of course, the patients come back with the AR after many years. He has come back with a paravalvular leak. Now there are two things to assess in these things. Now what are the hemodynamic consequences of this aortic regurgitation? One thing is there, because of the aortic regurgitation, which the LV gets filled up during this thing, the LV volume overload occurs because it is getting filled by two places. One is across the aortic valve and another is per the mitral valve. And next, what happens in the diastolic phase when the LV gets filled up? If you look at this, the left ventricular end diastolic pressure rises extensively. Okay. Now what happens? AR is occurring in diastole, and the LV is getting filled from the diastole into the LV, so the end diastolic pressure rises. So what happens if the end diastolic pressure rises to such an extent that is in diastole, it tries to push the blood from the LV into the LA. That means you tend to have a feature of a diastolic MR. We have to understand that. Normally the mitral regurgitation occurs in systole, but because of the severe AR, it tries to push the blood back into the LA. You can have a diastolic MR, that is before the mitral leaflets close, you tend to have a flow back into the LA. That is known as diastolic MR. Now because the mitral leaflets are competent, there is no turbulence across the mitral leaflets, and there is no obstruction to the flow, you tend to have a clear laminar flow back into the LA. That means you have a red color flowing back towards the transducer. This is the diastolic MR. Now how do you quantify this, whether it is occurring in diastole or systole? That is the reason why while doing a TE, you need to have a electrocardiogram running. Now, if you see, this is a very good image. Here, if you see on the right side, see, systolic MR is a holosystolic flow. It is a pansystolic. Throughout the systole, there will be a regurgitation. That means from the R wave to the end of T wave on the right side, you can make out. This is the actual MR, systolic flow MR. But on the left side, if you see there, see the regurgitation is occurring. It is beginning in the diastolic phase only. You can see the jet is rising here in the end diastole and then progressing into the systole and ending at the end of the T wave. This is diastolic MR. This is one of the best ways to quantify the diastolic MR. Okay, I hope everybody understood this. So that's how you quantify a diastolic MR. Now, what are the limitations? Suppose it's a aortic stenosis or a mitral stenosis. If it is a consequence of this thing, AR, if it is associated with aortic stenosis, it overestimates the pressure gradient due to the increased flow. If it is a mitral stenosis, it shortens the pressure half time, so you underestimate the severity of mitral stenosis or overestimate the mitral valve area. That is one of the things. So in short, what I would like to say is, whatever your assessment of the echo may be, but still clinically, if you look at the patient and the patient data, you would integrate that with the echo findings and then come to a conclusion of what therapeutic procedures you are going to suggest to the surgeons. So then only you can become a better echocardiographer. Thank you very much.